Good morning, all my friends. Happy Tuesday. I had to check. I don't know about you guys, but these weeks feel long and short all at the same time. So happy Tuesday. So happy to be in here today. We're going to talk about endometriosis this week. Something that I mentioned a few weeks ago now, that we were going to do a big endometriosis lecture. I've decided to make it a series because I don't want to come on here and talk for an hour. So we're going to do 3 separate videos, short and sweet, to the point. I'm here to answer all of your questions. Today we're going to get into just some really basic things about endo and how it can be impacting your fertility. So if you are here joining me live and you're new to the community, I am Dr. Kelsey Duncan. I'm a naturopathic doctor and the founder of the Fertility Confidence method, and it is my mission in life to help women balance their hormones and make babies. So we're going to talk about endometriosis today. If you're here with me live, let me know you can hear me. Okay, just give me a thumbs up or throw a comment in that comment box before we get in too deep and I find out my tech's not working for me, because that happens. I have some notes here, so you might see me checking on my notes. Make sure I don't miss any of the good juicy information. I had put this presentation together for an event I was a part of back in June, maybe May, that unfortunately had to get rescheduled just with COVID and everything going on. So I wanted to take all of that research and everything that I put together and give it back to you guys here. So I am going to just jump right in. So my opinion of endometriosis is that it's probably one of the most mishandled women's health issues in medicine. That and miscarriage are probably 2 of the things that I feel are just very, very mishandled in our medical community. On average, it takes about 7 to 10 years for a woman to get a diagnosis of endometriosis. It's only diagnosed properly through laparoscopic surgery. So gold standard of care is that it will be diagnosed through laparoscopic surgery. We really don't see it on ultrasound. We maybe can pick it up on MRI, but still not gold standard, and most people aren't sending people off for MRIs willy-nilly if you have menstrual cramps. So typically what happens when someone is having debilitating pain is they're just being told it's par for the course of being a woman, or they're put on the birth control pill. And if you're actively trying to conceive, that's obviously not a valuable option right now. Let me know if any of you are listening, even if you're listening to the replay. Is this something that you've gone through in your lifetime? If you don't mind sharing a little bit about your story, are you someone who's been having pretty severe cramping and just being kind of brushed off by your doctor, and you've always sort of wondered if endometriosis is at play for you? And oftentimes I have women coming to see me who have been dealing with this since they were a teenager and still aren't having a proper diagnosis, or still aren't being taken seriously, even when they're trying to conceive. So a lot of times women are told, just come back when you're trying to get pregnant, and if it's not working, we'll look into it then. Like, I hear that quite often from clients that I'm working with. And even still, I'm having women come into my practice who are actively trying to conceive and are still being told that laparoscopic surgery just isn't an option for them, even though they check all of the boxes. So it takes a long time to get diagnosed because it's just not taken seriously in the medical community, unfortunately. And we don't really have any other way to diagnose it beyond laparoscopic surgery. And a lot of times I think we're just saying it's not worth the surgery. Yes, there's a potential for scar tissue, but there's also the potential to change the quality of life of a woman and give them a better opportunity of conceiving. So it's a very tricky thing to get diagnosed. We do have, a very soft marker in the blood work. So there's literature out there now to support checking CA-125 in your blood work to get a gauge on potential disease severity. So if CA-125 comes back positive, then there is a chance of correlation there between endometriosis. But if it comes back negative, that doesn't necessarily mean endometriosis isn't present. So it's not the most specific, it's not the most sensitive test by any means, but it can be a good way to get your foot in the door with assessment and laparoscopic surgery if your CA-125 does in fact come back positive. Now, CA-125 is also a marker for ovarian cancer. So if it is coming back elevated or positive, we need to do our due diligence as well and get an ultrasound of your ovaries and make sure that there's nothing else potentially going on there. So something just to keep in the back of your mind. And if you do any research on CA-125, it's definitely going to come up. So don't be scared. Usually if I see it come back high or elevated, I just requisition those clients to have an ultrasound done just to make sure nothing else is going on, and then push forward with the endo diagnosis. Another thing to check that does not confirm or rule out endometriosis is vitamin D. It is, if you've been here long enough, you know that vitamin D is probably one of my most favorite things to check for a wide variety of reasons in women's health, but just in health in general. I honestly believe every single person should have their vitamin D checked twice a year, once in the spring, once in the fall, to tailor your dosage for you. But if vitamin D is low, if you are vitamin D deficient, then you actually can have worsened severity of endometriosis, and it can actually cause further progression. So they're seeing increased disease severity and increased progression of endo with low vitamin D status. And they're actually seeing in the research that treatment with vitamin D can improve endo markers. So those are the two things from a blood work standpoint that we can do to get a little bit of help in terms of treatment, in terms of diagnostics, but gold standard of care is that laparoscopic surgery. Now, it's really important to mention here that endometriosis is an inflammatory condition. It's not necessarily a hormonal condition, meaning high estrogen does not cause endometriosis, but high estrogen can inflame that tissue. The endometrial tissue is responsive to estrogen. So high estrogen and surges of estrogen can cause pain, can cause the tissue to grow and swell. It can exacerbate your symptoms, but it's not the root cause of what is going on. And I hear this quite a bit is, oh, I have endometriosis, I must have estrogen dominance. And it's not necessarily true. You don't necessarily have estrogen dominance. So looking into your hormones versus just trying to suppress your estrogen can be really helpful. I know that women who are, up in the stage 3, stage 4, they're often getting put on Lupron and the pill, things to really turn your estrogen down, and it will help. Having no cycles, having no surges in estrogen will definitely help control pain. Again, if you are in a stage of life where you are not actively trying to conceive, but if you are actively trying to conceive, then doing those things just isn't really a valuable option for you. So we need to find, first and foremost, other ways to manage your pain, but also we need to find ways to decrease your inflammation and the impact it might be having on your TTC journey. And we need to get you laparoscopic surgery. We need to get you a proper diagnosis so we know if excision surgery should be on the table, if removal through the lap surgery is all that you need to help improve your chances of making a baby. One of the big things you can do to really just gauge disease severity and how things are changing is track your medication usage. So if you're someone who needs Tylenol, Advil, Motrin, naproxen throughout your cycle and or throughout the month, if you're having pelvic pain outside of your cycle, track that. Keep a log of how much, what dosage, what you're taking and when, and take that into your doctor. You should not need pain medication more than once or twice in your cycle and more than just a minimal dosage. You shouldn't need pain medication at all, in my humble opinion. If you are having menstrual cramps to a point where you're needing medication to function, we need to look into why that's going on. And there's a lot we can do from a naturopathic perspective to help manage your pain and to help improve your quality of life by dealing with the root cause issue there versus just slapping a Band-Aid on it with the Tylenol. So I'm not anti-medication by any means. Girls got to work. You got to do something. You got to keep up with your family. There's life happens. And if you can't manage then popping some Tylenol is completely fine. But if you're needing to do this consistently and at a high volume, if you're someone who actually goes beyond what the bottle tells you to take, if you need to mix medications to actually get relief, these are all potential signs that something more than just menstrual cramps is actually going on. And these are things we need to watch out for if you're struggling to get pregnant, because this might be a sign of either hormonal imbalances, physical disruptions that might be causing your fertility issues, and or endometriosis. So when it comes to the research, we don't actually have a lot of studies in terms of natural support for disease reversal, meaning I don't have anything really in my toolkit that's going to shrink lesions or I want to say destroy lesions, but that's so barbaric. Disease reversal. So actually getting rid of endometrial tissue. The only way that's going to happen is if it is removed. They can remove it during laparoscopic surgery, or you might need to do something called excision surgery, which is a little bit more invasive, obviously, and definitely the gold standard when it comes to removal. Both options, there are an opportunity for recurrence. Unfortunately, excision a lot less so, but it also really depends on your surgeon. It really depends on the skill. So that is a huge kind of piece with living with endo, is that even once you have the surgery, it's still something you likely will have to deal with, but you might have a few years of great quality of life, and then we can use the naturopathic principles to help manage things post-surgery to make sure you're healing well, but also your body's at a place where it's not the best environment for the endometrial tissue to regrow. So most of the research that we do have is done in dysmenorrhea. So that's just the medical term for painful periods. That means we have some literature specific in endometriosis patients, but usually we're just looking at painful periods, which is fine. We can extrapolate some of that data for sure. And in part 2 and part 3 of this series, I'm going to go more into the research that I'm mentioning here. But depending on the severity of the endo, depending on where the tissue is, it can greatly impact your chances of trying to get pregnant. So if any of this is resonating with you, which I'm just going to stop really quickly and say, I'm sorry if you are commenting. I apparently can't see them today. Facebook likes to throw me curveballs like that. I'll go back at the end when I shut this down and just answer any questions that do pop up. So bear with me here because I unfortunately can't see them. But if you are someone who is resonating with what I just said, if you are someone who needs to take an excessive amount of medication, if you're missing days of work, if you're having a hard time getting out of bed, if you're feeling nauseous, if you're insanely bloated to the point where you actually have to have different clothes during your period, if you have pain with sex or pain with bowel movements, these are all potential signs that endometriosis might be at play. And it's definitely something I would bring up with your doctor, regardless if you're trying to get pregnant or not, but definitely if you're struggling to get pregnant. These are things we don't want to miss, and there's no need for you to have to wait a year or 2 years of struggling to get pregnant to get answers with this. Like I'm saying, it's very, very hard to get a diagnosis. You need to find someone that is going to take this seriously, and unfortunately, in my experience thus far here in Southern Ontario, and also having conversations with women all across North America, it's just not something that's taken very seriously. So I've been creating a network of women who can help put people together with practitioners who are endometriosis experts. And I think that's a really big factor here, especially if you're struggling to get pregnant. And it just breaks my heart that we don't have access to these tools and the surgery as readily when it can be such a game changer in terms of your quality of life, not just of your fertility journey, but in terms of you being able to function day to day, not dread your periods, actually be able to get up and go to work, not have to medicate, not have to take opioids, to be able to function during the day. So this is something that is a bit near and dear to my heart, just because I feel like it's so incredibly mismanaged in our medical community. But when it comes to fertility, there's a few ways that endometriosis might be impacting your chances of conceiving. So it's very dependent on where the tissue is. Endometriosis is just endometrial tissue growing, where it shouldn't be. If it has covered the openings of your fallopian tubes, then even if you are ovulating, that egg is never actually going to make it into the uterus. So this is something where doing an HSG can come into play, actually checking and making sure your tubes are open. So maybe you're not getting that laparoscopic surgery, but if at least you've had a clear HSG, we know that that egg is getting to where it needs to go. And we're not potentially dealing with any endometrial tissue over top of the fallopian tubes. But something to think about, it might be blocking your ovulation. And this could be happening, not to scare anybody, but this could be happening without you even really having super severe symptoms. So definitely HSG on the table if you've been trying for a year. For sure. I wish we could do it even less, but I unfortunately can't order them, and most clinics aren't going to be doing them until you've been trying for a year. Unless you're over the age of 35, then they will do them if you've been trying for 6 months. So something to think about. Also, depending on where it is in the uterus, maybe it's diffuse all over the uterus, maybe it's just in some certain locations, but if that is where that embryo is trying to implant, it's not going to be able to. So this is another factor in terms of ruling out any physical abnormalities. And like I said, an ultrasound really isn't going to pick this up unless we're dealing with a larger endometrioma, which isn't necessarily endometriosis, but we can kind of deduce and assume that it is. And if that is in the way, if that is causing a physical block, then we can remove the endometrioma and see what that changes, but we also should be doing a deeper dive in terms of what else might be going on from an endometriosis standpoint. And then the last piece is, of course, inflammation. Like I said, this is an inflammatory condition, and inflammation is one of the two huge pieces when you're trying to get pregnant and nothing's working for you. It's likely because you're not looking at inflammation. You're not doing things to help with inflammation. Taking a prenatal does not help with inflammation. It does not help improve your chances of conceiving. So looking into inflammation and principles, nutrition and lifestyle supplement factors to help reduce inflammation in the body is also going to help your quality of life in terms of your endometriosis and the pain that you experience, but it's also going to improve your chances of conceiving. When we're dealing with high levels of inflammation, we're dealing with higher levels of prostaglandins and reactive oxygen species and AGEs. Those are going to impact egg quality. So if your body is this environment of inflammation, your egg quality is actually going to suffer. So taking CoQ10 and NAC and inositol, antioxidants to help support egg quality are great. But if you're still living in this inflamed environment, no amount of supplementation is really going to impact you to the best of its ability. We really have to actually do the hard work. We have to deal with the food part, the lifestyle part, the sleep, the stress, to actually help reduce inflammation in the body to really make drastic change. And you're going to see it at both angles. It's going to help your fertility, but it's also going to help from an endometriosis standpoint. Another piece here with inflammation is if your body is chronically inflamed, your body perceives that as stress. It doesn't discern between physical and mental stress. So it's no different than you having a deadline at work. If your body is constantly inflamed, it's going to increase your cortisol levels, which is your stress hormone. And when our cortisol is high, when our stress is high, your parasympathetic nervous system is stunted and your body really doesn't care about making a baby. Getting pregnant is not high on its list. What's high on its list is surviving. And if it's constantly under attack, if your cortisol is high, if you're inflamed, it's really not going to be all that bothered with ovulation or with really protecting a pregnancy. So this is another piece where it can be driving the stress factor that can be negatively impacting your ability to conceive. And on top of that, if your cortisol is high, this is your umbrella hormone. So everything else is going to be impacted. Your thyroid is going to be impacted. Your insulin is going to be impacted. Your estrogen, your progesterone production will all be impacted if your cortisol is high. And that's coming from inflammation, which is coming from the endometriosis. So you can see here that everything is really linked, coming back into how hormones do come into play from an endometriosis standpoint. And really at the end of the day, we need to be dealing with and working with the inflammatory piece that comes along with that. So I am going to go, hopefully that was helpful. I'm going to go more into detail in part 2 of this series on the nutrition, the lifestyle research around endometriosis, and also how those things can correlate from a fertility standpoint as well, what you should be doing to help your chances and also to help improve your quality of life. And then part 3, we're actually going to get into the research around the supplement piece in terms of how we can be reducing pain, but also improving fertility and reducing inflammation. So we're going to do those over the next week. I'll always give you a heads up before we do it. Hopefully this is helpful for you. If you have any questions and you're watching the replay, throw those in that comment box. Make sure you tag me. So put @Kelsey Duncan. I'll come back and answer them, and we will talk soon. I hope everyone has a really wonderful day.